This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Welcome to the Neurology podcast. My name's Gordon Smith. I'm a neuromuscular neurologist and chair of the department at Virginia Commonwealth University. I'm super excited to have the opportunity to talk today to a leader in the field, Peter van den Bergh, who is the director of the Neuromuscular Reference Center EMG Lab, Neuromuscular Pathology Lab, all in the Department of Neurology at University Hospital Saint-Luc, Brussels, Belgium. Dr. van den Bergh was the lead author on a really important publication, which is the EAN PNS guideline on the diagnosis and treatment of CIDP. And Peter's been kind enough to join me today on the podcast to talk about that. Peter, welcome to the podcast.
Thank you very much, Gordon, for this very kind introduction.
I'm really excited to talk to you. Congratulations on a remarkable job. The article is a real tour de force and a must read for anyone caring for CIDP. Maybe we can begin by just talking about why revise it now. Many of our listeners will remember that there was a similar guideline, which I think was the second, published in 2010 that worked pretty well. What made you all decide to update it now?
The first version of the guideline was published in 2005, and then we did the first revision in 2010. And we thought that the second revision was absolutely necessary because there is significant progress in the clinical and basic research, which leads to a better understanding and treatment of CIDP. I would like to emphasize that misdiagnosis of CIDP is common, and that is mainly something that occurs in CIDP forms that are different from typical CIDP. Therefore, we have paid a lot of attention to adjust criteria for other than typical CIDP forms to try to improve their specificity.
Well, we're going to spend some time talking about variants of CIDP and other closely related disorders. But before we get into those specifics, maybe we can kind of get to the punchline first. How do you envision neurologists and neurology providers using this guidance, using the guideline in their daily clinical practice?
Well, an important new feature in the guideline are 3 flowcharts. And these serve as a quick practical reference for the clinician. Flowchart 1 covers the diagnostic criteria and categories of the different forms of CIDP. Flowchart 2 lists the clinical and laboratory red flags that suggest another diagnosis. And finally, flowchart 3 shows the treatment algorithms for CIDP. Next, there are 6 tables. And these tables show at a glance the clinical and electrophysiological criteria. They show the differential diagnostic disorders, the investigations to be considered, and also a summary of the criteria for the diagnostic categories.
You know, Peter, I'm betting that probably already have these posted in your EMG lab, and they'll be going up in ours as well. Before we talk about the criteria themselves, your team made some changes in the classification system regarding typical CIDP versus variants, as well as change in the definition of levels of diagnostic certainty. And since we're going to be talking about these in more detail in a moment, can you just cover these changes and why they were made?
Typical CIDP is the most common CIDP form. Other forms were labeled predominantly distal, asymmetric, pure motor, and pure sensory CIDP. And now we have proposed the following labels: distal CIDP, multifocal and focal CIDP, motor CIDP, and sensory CIDP. So this is more easy and more succinct. We used to call these forms atypical CIDP, but they really are CIDP variants because each of these has well-defined characteristics. And the CIDP umbrella is used because of a common denominator for these variants, and these are inflammation and demyelination. We used to have 3 diagnostic categories: definite, probable, and possible. Now, it has become clear over the years that the diagnostic accuracy of the electrophysiological criteria for probable and definite CIDP is virtually identical. And because of this, we have reduced the levels of diagnostic certainty to only 2 categories: possible CIDP and CIDP. And then finally, we abandoned the adjective definite, since there is no diagnostic gold standard that allows us to say that it is definite CIDP.
All right, Peter, I guess we're ready to go. That's a great introduction. Perhaps you can walk us through the clinical and electrodiagnostic criteria that have been updated for CIDP and its variants.
Well, clinical criteria for all forms of CIDP include 1, the pattern of weakness and sensory involvement, 2, progression over at least 8 weeks, and 3, decreased or absent tender reflexes. In typical CIDP, motor and sensory involvement is proximal and distal and affects the 4 limbs. CIDP variants, there the features are the same as in typical CIDP, but in distal CIDP there is no proximal involvement. In multifocal CIDP, there is involvement of 2 limbs, usually the upper limbs and asymmetrically. And in focal CIDP, there is only 1 limb involved. There is no sensory involvement in motor CIDP, and vice versa, no motor involvement in sensory CIDP. Now, instead of having electrophysiological criteria for definite, probable, and possible CIDP, we now have criteria weakly supportive of demyelination for possible CIDP and strongly supportive for CIDP. And these are based on well-defined deviation from normal reference values for 7 motor nerve conduction parameters. And these have not really changed that much. Fulfillment of criteria of conduction parameters in 2 nerves qualifies for the diagnosis of CIDP and for possible CIDP if fulfilled in only 1 nerve. A new feature in the guideline is the inclusion of sensory nerve conduction studies as an integral part of the electrophysiological criteria. And therefore, they are not supportive criteria anymore. Sensory conduction abnormalities in 2 nerves are required for all forms of CIDP except motor CIDP, where, of course, sensory conduction should be normal. We also have specific criteria for possible sensory CIDP, but the diagnosis cannot really be upgraded to CIDP because the evidence for this, the certainty of the evidence is not large enough.
I wonder if you could reflect on how you think these criteria will address the drivers of that misdiagnosis. And maybe there's just 1 or 2 pearls you might provide for our listeners to focus on as they go about using these criteria in clinical practice.
It's true that misdiagnosis is a major problem, and it affects mainly the CIDP variants. What we have done for each of these variants, we now have developed more specific electrodiagnostic criteria to try to avoid misdiagnosis. An example is diabetic neuropathy, which can be confused with distal CIDP. And what we have done is to require that nerve conduction abnormalities, motor nerve conduction abnormalities, should be present in 2 upper limb nerves. If they're present only in lower limb nerves, diagnosis of CIDP is not possible. It can be at most possible CIDP.
That's super helpful. Thanks, Peter. Why don't we move on? And I've got a question regarding what wasn't included as CIDP. I think your task force had to make a couple of tough decisions in this regard, and I'm particularly interested in talking about nodopathies and paranodopathies. As many of our listeners will know, that these have been something that we've learned a lot about in the last 10 years. I would say a very major advance in the field. Why weren't these included as CIDP variants? They're mentioned separately.
We decided to name these neuropathies autoimmune nodopathies, and before they were considered a subset of CIDP, usually with a distal or typical phenotype. They are caused by antibodies against cell adhesion molecules tightly securing the axoglial junction at the node of Ranvier and the paranode. And these antibodies lead to detachment of the terminal myelin loops from the nodal and paranodal axolemma with disappearance of the barrier between potassium and sodium channels and diffusion of the driving current, which is necessary for action potential generation and saltatory conduction. The result is conduction slowing and conduction block, but there is no demyelination. Moreover, since these antibodies are of the IgG4 subtype, they cannot activate complement and they do not cause inflammation. Because the pathophysiology is very different from that of CIDP, and because the response to proven treatments is very poor, we decided to separate these autoimmune nodopathies from CIDP.
I do recall that the guideline recommends ordering nodal and perinodal antibodies in all patients with a clinical suspicion of CIDP. Just to remind our listeners that the phenotype does have overlap. It's really the mechanism implied by the presence of these antibodies that's the issue. Is that right?
Yes, ideally we should look for these antibodies in every patient suspected of CIDP, but in daily practice, I think we are not ready to do this yet. So what we have proposed in the guideline is to look for the red flags. For example, patients with an aggressive onset, almost like Guillain-Barré syndrome, may qualify for looking at these antibodies. And there are also things like very high spinal fluid protein. These patients often have distal involvement with ataxia, and these give a clue for the diagnosis of an autoimmune nodopathy.
Another disease of interest that wasn't classified as CIDP is CISP. Can you talk to us a little bit about CISP and how that differs from sensory CIDP?
CISP stands for chronic inflammatory sensory polyradiculopathy and clinically presents with ataxia and sensory loss. CISP has been considered a sensory CIDP variant in the former versions of the CIDP guideline because it fulfills the clinical criteria for sensory CIDP. We decided to exclude CISP from the CIDP spectrum because it's not a neuropathy, and indeed, nerve conduction studies are strictly normal. It is, in fact, a proximal sensory radiculopathy, probably inflammatory and demyelinating, and responsive to treatment, but the dorsal root ganglion neurons are intact, and this is why, indeed, sensory nerve conduction studies are completely normal. There is some controversy about this because some feel that in some countries the CIDP label would facilitate access to IVIG and its reimbursement.
That's certainly been a concern here in the United States. Any thoughts about that or words of wisdom? I don't know if you confront this issue in Belgium. We certainly do in the United States, and in my experience, it varies a bit by region. Any wisdom there to help our listeners?
It's a controversial issue for these reasons, but from a purely scientific point of view, there are clear-cut differences. Sometimes there may also be misdiagnosis because it has been said that sensory nerve constructions are completely normal, that it is because the technique is not sufficiently sensitive. And the other thing is that, for example, in my country, it would be possible to give IVIG because there is enough evidence that indeed these patients may respond to treatment, not only IVIG, but also corticosteroids. So this was what the task force decided. They thought that it would not necessarily be deleterious to patients because they would not have access to treatment.
Yeah, I suspect others might argue that patients with CISP were diagnosed or coded as CIDP, but I really get your point about scientific rigor, the underlying mechanism. And I think this is important for clinical and trial enrollment. You know, we actually have trials going on for CIDP that have been enrolling nodopathy patients, right? And you already talked about that. So I think you did a great job of explaining the logic. Maybe we can shift, unless you want to interject more about this topic, and move on to talk about other diagnostic approaches. So the task force identified a number of criteria that can be used to support a CIDP diagnosis, and there are a lot of them, but I wonder if you might talk to us about the role of CSF examination and MRI.
If the diagnosis of possible CIDP cannot be reached by clinical and electrodiagnostic criteria, then supportive criteria can be used to try to upgrade the diagnosis from possible CIDP to CIDP. And to do so, 2 supportive criteria need to be fulfilled. There are 4 kinds of supportive criteria. 1, objective response to treatment. 2, spinal fluid. 3, imaging. And 4, nerve biopsy. Now, there's an important additional feature that we introduced in the recent version of the guideline. In cases of typical CIDP with motor conduction abnormalities that do not fulfill minimal criteria, a diagnosis of possible CIDP is now allowed if there is objective response to treatment and fulfillment of at least 1 other supportive criterion. So let's move to spinal fluid. Spinal fluid analysis is not indicated when the diagnosis is already made by clinical and electrodiagnostic criteria. But it is recommended to exclude other diagnoses, for example, cases with acute, subacute, aggressive onset. These can be due to nodopathy. Or also when infection or malignancy is suspected. It is true, however, that over-reliance on increased spinal fluid protein is prone to lead to misdiagnosis. An example would be diabetic neuropathy. But also age is important. We have normal values for spinal fluid protein for younger people, even adults, but it is clear now that once over age 50, that these values may rise. This means that you cannot use the lab cutoffs that we use for patients who are middle-aged. And so that's also a reason that can lead a reason for misdiagnosis. Then let me talk a little bit about imaging. We now advise to use ultrasound and not only MRI. In the former guideline, there was only MRI as a supportive criterion. Ultrasound may even be superior for upper extremities since well-defined cutoffs for nerve enlargement are now available for cervical roots, brachial plexus, and upper limb nerves. Ultrasound has also the advantage to be readily available in the clinic next to electrodiagnosis. The results are immediate. It is inexpensive also. Now, it's true that for other indications like abnormalities of the lower limbs, that MRI has still its place to look for abnormalities of the lumbosacral roots and the lumbosacral plexuses.
Thanks, Peter. That's really a great answer. And I'd love to talk more about the supportive criteria, but I think we should leave some time to talk about treatment because the guideline not only covers recommendations and criteria for diagnosis, but how to go about treating these patients. And I wonder if you might be able to focus on first-line management of CIDP. For instance, how do we decide between IVIG, corticosteroids? What guidance did the task force have? And maybe throw Plex into the mix. What role does plasma exchange have in initial therapy of CIDP?
Well, before starting treatment, there are two preliminary conditions. First, adhering to diagnostic criteria is of utmost importance before considering to treat. Treatment can be very expensive and can have significant side effects. And second, treat only if there is disability and impairment, and treat only if there is active disease, which means objective worsening not explained by axonal loss. As induction treatment, there are three proven effective modalities: corticosteroids, immunoglobulins, and plasma exchange. Now, whether to choose first IVIG or corticosteroids is really not that important. There is no real preference, and we don't recommend something for this. But as daily practice has shown, IVIG may lead to short-term effectiveness. And of course, we are going to start with IVIG if corticosteroids are contraindicated. For motor CIDP, one should start also with IVIG because patients treated with corticosteroids may get worse if they have motor CIDP. Now, as for corticosteroid treatment, if you are looking for long-term effectiveness, this may be better. It's true that probably the beneficial effect may take a little bit longer to show up. Now, corticosteroids can also be used when IVIG is unaffordable or unavailable.
Well, Peter, thank you so much. This has really been an exciting and really enjoyable conversation. I've learned a lot, both about the diagnostic framework and how to go about managing CIDP. I think those tables and flowcharts are super helpful. I really encourage our listeners to take a look at the paper. I find a lot of guideline papers or diagnostic criteria papers to be dry. This is anything but super helpful clinically. It's in the Journal of the Peripheral Nervous System. So check it out. And Peter, thanks so much for talking with me today on the podcast.
Thank you, Gordon.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about. The views and opinions of the participants in this podcast do not necessarily reflect those of the journal Neurology or the AAN. Disclosures of the participants are included in the show descriptions, reached by a link on the neurology.org website.